joining in, but look, I think Alki needs no introduction. Today's topics on long-term treatment algorithms, including the role for biologics in the care of patients with CRS. Floor's yours, Alki.
Terrific. What I'll do, Ray, is I'll just share my screen. So I'll probably need you guys to unshare. Fantastic. Great. So you can see my slides, Ray?
Yes.
Fantastic. So I'm going to speak to you about how we manage our patients long-term following surgery and where biologics fit into the realm. Biologics are here, whether we like it or not, whether we're frightened of them or not. But certainly as ENTs, I think we need to take control of the domain of biologics and all the options that we can do before we put our patients on biologics. And what's interesting is that as ENTs, we've got no authority to prescribe biologics for asthma or for allergy, but respiratory doctors and allergists have the authority to prescribe it for patients with polyposis. And I think really we probably need to be more active in the area of advocating that as ENTs, we should be the ones prescribing it for patients with polyps. These are my disclosures. The relevant ones here is that I have received speakers' fees for both GSK and Sanofi, who are both manufacturers of biologic medications. And really briefly, we're all shifting away from this, and I think this has been really well sort of documented at all of our meetings. We've gone beyond simply thinking of patients with polyps or without polyps, as we know that chronic rhinosinusitis is more than this. And simply, if we're giving steroids for polyp patients and no steroids for non-polyp patients, we're doing our patients a disservice. I think we're doing ourselves a disservice as fully trained ENT specialists. We know that chronic rhinosinusitis has many different presentations and different sort of severities of disease that fit under the umbrella. We go from atopic disease with central compartment atopic syndrome, where we really have that central disease, to having patients with unilateral disease, periodontal in nature, or a fungal sinusitis, to sort of limited disease, and then widespread sinus disease. And really trying to treat all these patients with the same treatment algorithm is probably oversimplifying the issue.
Alki, are you sharing? Because we're not seeing your screen.
Yeah, I am sharing.
Okay, maybe it's just me.
I got it. I can see.
Oh. My
guys...
apologies.
Okay.
Can others see? Can we have another feedback?
So what we do know is that just as heterogeneous the presentations of sinusitis are and the end manifestations, as are the possible etiologies. And in the past, we've got caught up trying to treat sinusitis by understanding one or two etiologies, biofilms, fungal hypotheses, immune disorders or environmental issues. But what we really know that it's probably an interplay of all of these factors. And essentially, these factors all result in the same issue. They all result in epithelial barrier degeneration and dysfunction. And it's this common issue that then creates the underlying inflammation. And once we get the barrier dysfunction, and that's not obviously how you spell dysfunction, but we get an elaboration of the inflammatory cascade, recruitment of inflammatory cells, which then leads to the different types of chronic rhinosinusitis we see. And broadly, they're categorized into type 1, type 2, type 3 inflammation based on the inflammatory cytokines. And we're really understanding that there are probably even more subtypes or mixed endotypes out there as well. And this then finally manifests in what we see in our patients. Patients with and without polyps, patients with polypoid mucosa and polyps, patients with areas of polyposis and without polyps. And really, the phenotype is the end stage of this barrier dysfunction. I think this is a really important document, and there's some really nice free summaries on the internet of a whole host of individuals who've contributed to this. Richard and I both contributed, as have other Australian representatives, and it really, I think, dials down as to what we need to know about these patients. So in summary, we really can define our patients with chronic rhinosinusitis into patients with primary disease, where we really don't know the underlying etiology. And these are patients with type 2 and non-type 2 inflammation. And then we have patients where we have an identifiable cause, whether it be obstructive, an underlying autoimmune problem or immunodeficiency, or issues relating to mucociliary clearance, where we can actually find the identifiable cause. Now, these patients are then subcategorized, and I think, Richard, really it was your brainchild that put this forward, which I think really has simplified the way that we can think about sinusitis. But essentially, when we're looking at each of these forms, whether they be primary or secondary, we can really dull them down into groups based on whether or not they're localized or diffuse, and whether or not we're seeing manifestations of type 2 or non-type 2 inflammation. So in the past, and certainly as a registrar, and probably up to the first 3 or 4 years of being a consultant, we thought of maximal medical management of every patient having to have had oral antibiotics, washes, sprays, and steroids. And, we used to think that if we weren't offering all of these patients prior to offering surgery, we were medically negligent. But I think the thought of this is changing. And certainly, I don't prescribe antibiotics for my patients regularly unless they're having an infective exacerbation. I've got a positive swab with evidence of a purulent infection. And the reason for this is, I think, with our understanding of the microbiome and the long-term effects of antibiotics, and certainly the heavy use of antibiotics in the Western world, we may be creating a disease process by affecting the good and bad bacteria that live within the nose, the bowels, and anywhere else in the body. With prednisolone, typically this has been reserved for patients with polyps, and that's where all the high-level evidence is. And we used to think that we don't prescribe prednisolone if patients don't have polyps. Certainly, anecdotally, I think the patients that you can break the inflammatory cascade and perhaps avoid surgery are more likely to be the patients where you don't have polyps and you've got some scattered disease. And in these patients, prednisolone often reverses them in short courses. But obviously, this is contentious. It's something that I've seen anecdotally. We haven't backed it up with any good clinical trials, and it's something that we're researching at the moment as well. So we're shifting away from this idea of maximal medical therapy, where we're throwing the garden sink at the patient, to really appropriate medical therapy, where we're tailoring the treatments according to the disease process. And I think that's an important step forward when we see these patients for the first time. The role of surgery has also shifted from what we initially told our patients, where we're simply opening your sinuses to ventilate them and improve drainage. And we know that this alone isn't the role of surgery. It may assist in the short term, but unless we do more than this, these patients are going to get recurrence in the vast majority of patients with severe inflammation. And so we now think of surgery as not only opening the sinuses and improving their drainage, but also reducing as much of the inflammatory burden as possible. And certainly we know that if we can reduce that inflammatory burden down to a manageable amount that we can control with topical steroids, the body has a greater chance of overcoming this inflammatory burden and creating long-term health. And the sooner we do this after surgery, the sooner we normalize the sinuses, the better the patients do long-term. And probably, again, a video that Richard gave me a little while ago is the whole point of surgery, and probably the main role of surgery, is to facilitate access to topical drug delivery. We know that sprays don't penetrate into the sinuses. They're essentially a treatment of the anterior nasal cavity. And what we do with surgery is open up the sinuses so that we can deliver topical steroids via irrigations, high volume delivery systems right to all of the sinuses, so that we're really carpeting the sinonasal mucosa with an anti-inflammatory agent. And similarly to the way that we manage our long-term asthmatic patients, we're controlling the inflammation in sort of a preventative fashion. Steroid irrigations have become the mainstay of treatment, I think, for polyp and non-polyp patients. And certainly all my patients post-operatively will go into a short course, twice daily in the initial phase of their recovery, and then tailored down according to how quickly their inflammation responds endoscopically, and we control disease. And certainly I have no hesitations keeping on patients long-term twice daily, if they can do it, as long as this is needed, and sometimes indefinitely. I suppose probably a role of surgery that's now becoming very well researched and evident is we really are trying to endotype the disease process, because this is what's going to allow us to tailor the treatment beyond the regular treatments that we give post-operatively. The histopathology report is something that obviously I heard a few years ago, and now I've adopted into my practice, and I use a variant of the St. Vincent's report that you can see here. But essentially, the key factors of this report are: what type of inflammation do we have? Is it eosinophilic? Is it neutrophilic? What's the predominant cell? And are we seeing irreversible changes of disease, such as squamous metaplasia and fibrosis, or hyperplastic changes? Because these are the ones that are going to make these patients, sinus cripples and a lot harder to manage in the long term. So if we see a typical Caucasian polyp, and this is one of my patients, this is typically what we see histologically: florid submucosal eosinophilia, and this is how the report comes up. And for these patients, it's really a no-brainer how we manage them. We give them Pulmicort irrigations long-term. The safety studies are well published. There's very little, if any, systemic absorption. The amount of steroid that actually gets in contact with the nasal cavity is probably less than we give them when we're delivering a spray, which we know is entirely safe. The only patients to be careful in are the patients who have concurrent asthma steroid medications, because in a study that we published at Stanford, about 26 to 30% of these patients will get asymptomatic HPA axis suppression. It's completely reversible when you stop either the inhaler or the steroid wash. But these are patients who you probably should be checking the HPA axis on if they've got both asthma and sinus disease, and they're on inhalers and steroid irrigations. This is a classic example of a patient with eosinophilic inflammation. This was a patient that I operated on a year that I came back after my fellowship. We can see some widespread inflammation. We can see the middle meatus full, some inflammation sort of dripping down over the inferior turbinates, and this patient had polyposis. This patient underwent surgery. He was a young 23-year-old or 24-year-old male at the time. Really wasn't going to do his washes long-term, but promised that he would, like most of our patients do. And then the patient was lost to follow-up. He moved to Melbourne for an acting job, came back, was seen by a colleague of mine, who then rang me up and said, I don't know what sort of surgery you did, but this is what's happened. And you look at this as a new consultant thinking, geez, why did I do fellowships if I can't control disease? I'm pretty sure I did a pretty good job. So I went and did the CT scan of this patient. By this stage, the inflammatory load's way too big to get control with steroids. You could certainly try a course of oral steroids. You can try the washes, but these polyps are re-established, and it's very unlikely that you're going to gain good symptomatic control again due to the mucus trapping and the inflammatory burden within the sinuses. So I repeated the scan on the patient, and I was pretty happy that actually I'd done reasonable surgery. You can see the ethmoids are skeletonized, osteometal units are widely open, and despite this patient's got pretty significant disease recurrence, which is really indicating that is a failure of the ability to control his disease rather than a failure of surgery. And so I took the patient back to theatre, and I really, I suppose, refocused the conversation about the need to irrigate. And I think that when we consent our patients for surgery, you really need to have that spiel really rehearsed, that this is a long-term disease process, and give examples. It's like asthma, diabetes, hypertension. You need long-term management. And certainly these patients need long-term follow-up, and you need to book their post-operative appointments so that you can see what the sinuses are looking like. And most of them will tell you that they're getting slack with the irrigations because they're feeling quite well. But that's the time to pick up the inflammatory recurrence before they become symptomatic and before they need a revision procedure to rectify the problem. And here, again, we can see the skull base is well skeletonized. Frontal sinus ostium is as open as we can get it without drilling, but they've got florid disease recurrence. So this patient underwent revision surgery with me, and he underwent a drill out, and 3 months post-frontal drill out surgery, did really well. We can see nice open cavity, still some granulation tissue healing on that posterior septectomy, but we can see the sinus is widely open, and the tissue really does look healthy, like it did after his initial procedure. We can still see a little bit of subclinical inflammation of the skull base lining, And this is a patient that I would keep on steroid washes, probably reduce them down to once a day at this stage and follow them up in about 6 months unless they're getting an issue earlier. This patient, similar to a lot of our patients, felt great after the first 12 months, and then he stopped washing. But what he did this time was actually turn up for his follow-up down the track. And then 12 months following the drill out, these were his sinuses again. And he said, I'm losing my sense of smell. I admit I haven't been doing my washes because I don't feel blocked. And that's really often smell and blockage is what patients get motivated by to do their irrigations. And so I said to him, look, we haven't lost control of the disease. Let's get you back on the pulmocore irrigations. And lo and behold, 3 months of twice daily, 1 month of daily irrigations, and we got back to where we were. And here we can see the sinuses are looking healthy again. And so you can see that early intervention in this patient before those polyps become obstructive and trap secretions and inflammation, we can get control. Similar patient, this time we have a different disease predominance. We've got this sort of lymphocytic neutrophilic inflammation. We can see a lack of eosinophils in the high-powered field. And these are the patients that I've now begun to manage, as I've spoken many a time before, with low-dose clarithromycin. I think these patients, we often talk about macrolides being immunomodulating, given that we're giving them in subtherapeutic doses of 250 milligrams daily. But the more I see these patients, the more I think they've got a subclinical or chronic bacterial problem in their sinuses. And I think the macrolide's not only working on that immunomodulating action, but I think it's really doing something to the bacterial flora within the sinuses, because you go from seeing these patients full of this thick sort of mucus and mucopurulence to sort of having pristine sinuses. And again, this patient, early recurrence post-surgery, 4 months after the initial procedure, really haven't gained a lot of control. 3 months of macrolides, that polyp evaporated. And you do see this in a cohort of your patients where you'll see early polyp recurrence despite being on pulmocore washes. Have a look at the histology, and you'll often find that it's a lymphocytic problem. And I flag these patients because I have a low threshold to put them on macrolide therapy in the early post-operative period, especially if they're failing on steroid washes. So here's an early surgical success. Patient's done well post-surgery, pretty happy with how the surgery's gone. The ostia look great. Everything looks really, really healthy there. And yet they've recurred, as we saw in that patient before. And so these patients aren't surgical failures. There's nothing more that you could have done at that initial procedure. These are the medical failures. And these are the patients that I'm going to speak to you, sort of what do we have in terms of options if we're not getting control with the macrolides, if the lymphocytic, or the pulmocore, if they're eosinophilic. This is my algorithm for how I look at my patients when they fail endoscopically. I first want to know, especially if I haven't done the surgery, are they a technical failure? And here you can see a patient who's referred to me several weeks ago, who's had 3 previous sinus procedures. You can see they've had their turbinates completely resected, and they've really only had sort of minor sort of maxillary surgery. And this patient is told basically that nothing more can be done to them. And the GP reinforced this. And it wasn't until their GP passed away that a fresh GP said, well, actually, I think something can be done. Let's get a different opinion. So in this patient would be revision surgery. There's no point in putting biologics on this patient, even though by the criteria, they may fulfill biologics. This patient really needs good procedure, and he needs the sinuses opened up, the mucus evacuated, the inflammatory burden reduced, and then to get onto proper therapy. If it's not a technical failure, if the surgery was good, I encourage you to really interrogate your histology and find a histopathologist that will give you that information that we show you on that synoptic. There's certainly some groups out there that can be resistant to doing this because it's more work for them, but you need to get an organization that will do it for you. And is it neutrophilic or lymphocytic? If it is, consider macrolides, and you might be saving this patient revision surgery. If it's eosinophilic, budesonide really has become the mainstay of treatment. Very safe, very effective. If they've got poor disease control, despite budesonide, what you need to start thinking about is this an access problem? You know, have we got disease recurrence in the frontal sinuses, which are inherently very difficult to get washers into based on the fact that they're sitting in a non-dependent position, that they've got narrow ostia? Do they have mucus disease in the floor of the maxillary sinus? And if they do, and access isn't adequate, this is a patient that you should perform a more extended procedure on or refer them on for an extended procedure. And what we mean by that is a modified Lothrop or a Caroline's window if it's unilateral disease, or a modified medial maxillectomy or an extended maxillary antrostomy. And in a vast majority of these patients, we can actually get them quite good. Once we've opened the sinuses up, we've really reduced that inflammatory burden as much as possible, and we can get the washers to where they need to go and start them really early in the post-operative period. If the patient's got good access and they've had maximal surgery, and I'd consider maximal surgery a drill out and an extended antrostomy, and they're still failing, this is the group that I then consider biologics in. So you can see that we haven't jumped straight to biologics from that very first simple technical failure. We've really gone through an algorithm of trying effective, safe treatments that aren't going to sap the healthcare system of precious dollars, which is becoming relevant in today's economic, but also health climate. So here's a refractory patient. Patient's had good surgery again, wide open antrostomies. This patient we would take to do a drill out, and we did a drill out on this patient, and we can see that we've got a nice diameter, but despite this, we've got the secretions pooling and they're failing, probably partly due to compliance, but also due to the disease process. And certainly, although patients tell you that they irrigate twice a day consistently, we're all humans, and there are people that will irrigate more consistently than others and others that won't. And certainly this is a cohort where you need to gain control some other way. And the cohort that we're talking about is this sort of diffuse bilateral type 2 inflammatory disease, and really these patients with polyps and with thick acidophilic mucin. And so this is a patient who's got polyp recurrence. These are patients who have lots of eosinophils in the tissue, in the blood. They often have an elevated IgE. If you ask them about asthma, they've often got adult onset asthma, may or may not have aspirin exacerbated respiratory disease. And they're living off steroids prescribed by GPs, respiratory physicians, ourselves, or often self-medicating so that they can smell or breathe. And often these patients have had a whole history of, surgery for their sinuses. So historically, we've just thrown prednisolone at them. And what we know is that prednisolone is not a safe drug. And certainly it was at the AEST meeting where a respiratory physician spoke about, the toxicity of steroids and his reluctance to prescribe steroids at all, that really made me look into this further. And papers have been published looking at the relative risk of a complication of any steroid use. And in this particular study, which was a retrospective sort of cohort observational study where they looked at patients who had received steroids in their life and those patients who hadn't, and they looked at the relative risk of developing complications. And there was a statistically significant increase in a huge number of complications in patients who had received steroids. Furthermore, what's frightening is that the cumulative dose of steroids isn't as high as we think. And this particular study, that same paper, suggested that the safe cumulative dose of steroids in your lifetime is about 1 gram. And to think that when we prescribe a 3-week course or 3-week taper, could be prescribing in the order of 300 to 400 milligrams of steroids, we really don't have a huge number of doses that we can safely prescribe. And certainly that old adage that if you're having 2 courses of steroids a year, that's safe, that's no longer the truth. And these patients get long-term complications that may not be initially apparent, when we see them during our 3 or 4 years that we're in contact with them, but down the track they do. And some some authors and recent studies suggest that the safe cumulative dose in your lifetime might be about 500 milligrams. So really, I think steroids, although they're great at making people feel better, are really becoming probably a toxin or a poison as well that we should probably be avoiding at all costs. So really, I try to justify who I'm going to give steroids to. If I've got a patient with polyps coming out of the nose, you know, the chance of getting them better with a course of steroids and staying better, although you can offer it and discuss potential side effects for them, really is low. And really, we need to rationalize if for those patients, you know, we just do upfront surgery. So again, very controversial given what we've been taught and what's in the literature. But probably from my practice, which is, you know, entirely rhinological, I can count on my sort of fingers the number of patients that have had steroids and not gone on to require surgery with grade 2 to grade 3 polyposis. So the evidence of recurrent polyps, a high burden of uncontrolled disease, and the side effects that we're getting from steroids really was the motivator for, you know, people to develop alternative therapies. And that's where the evolution of biologics has come into play. For sinusitis, we now have biologics that target IgE and the interleukin-5 pathways, either the receptor or the interleukin-5 itself, and the interleukin-4 alpha component of the receptor as well. And these ones are prescribed worldwide for nasal polyps. The only one that we've got approval for in Australia for polyps is mepolizumab, although probably in the US and European literature, that's a distant second to dupilumab in terms of preference for control of polyp disease. What we know from the studies and the well-designed randomized controlled trials is that all of these biologics do have a benefit. They improve polyp size of variable ranges. They also improve symptom scores, and all of them improve the scores above the minimal clinically important difference. Often sense of smell is the one that's improved the most. And quality of life consequently also improves across the board for mepolizumab, omalizumab, and dupilumab. If we look at dupilumab, that's the only one that's shown radiologically to improve Lund-Mackay scores to a statistically significant level. And both dupilumab and mepolizumab, when they've looked at long-term steroid use, dramatically reduce the amount of steroid courses required. Dupilumab considerably better than mepolizumab. So I think these are important studies. Obviously, the studies comparing the different biologics directly in randomized trials have not been performed. So the next best thing that we have are network analyses, which allow us to compare 3 or more interventions in a sort of indirect way, but looking at the literature and the raw data. And what you can see from this table, and there's been a couple of these done, is that dupilumab across the board seems to perform the best. That green box is indicative of being most beneficial with relatively low side effects, sort of compared to other therapies. For certain patients, and if you choose the correct patients, omalizumab is important and beneficial. And mepolizumab, although it certainly has benefit and lights up in green, it's probably across the board in terms of symptom scores, smell scores, use of oral corticosteroids, and polyp size, not as beneficial as dupilumab in the data that we're seeing coming out of Europe and the US. This is another network analysis where they graphically compare the different agents, and we can see in those circles, this is dupilumab compared against the other biologics. And we can see that in terms of nasal polyp score and nasal congestion, both at 24 weeks and at the end of the treatment, dupilumab's outperforming on the whole the other agents in terms of nasal congestion and nasal polyp scores. This is also what we're seeing in terms of smell and also in terms of symptom scores. So really, all seem to be better than placebos for the large part, except probably benralizumab, which is probably more effective in asthma than in nasal polyp disease control. But dupilumab's probably the best of the lot in these network analyses. And yet another network analysis, and this is a different graphical representation, Here we can see that green dotted line, which is the dupilumab, and the area under that curve is indicative of the benefit. So you can see, again, omalizumab and dupilumab and mepolizumab are all showing benefit above that sort of dark green placebo. But again, dupilumab's performing better. And these are 3 independent network analyses. There have been real-world studies done as well, and these are where obviously they're not in randomized controlled trials, but they look at cohorts in patients that we see that aren't checked as frequently with stringent criteria. But all of these studies have also shown that dupilumab seems to be quite beneficial, and they've all shown positive effects on symptoms and polyp scores. I want to highlight 2 of these studies. This is a study from Italy. This was of 648 patients, 19 centers, and looked at dupilumab every 2 weeks in a subcutaneous dose. Graphically, you can see polyps, snot, and smell all improve. And I think this is where it gets interesting when you delve into the data. We can see that nasal polyp score improves pretty quickly. At 1 month, patients will notice a difference. And then sort of by 3 months, they're getting almost maximal benefit, both in symptom scores and polyp scores. So the improvement is really quite quickly. Where it gets a bit frightening for us as surgeons is that if you look at patients who having surgery and haven't had surgery, the improvements are pretty similar. So obviously these cohorts could be different. There might be biases involved in the patients who were selected to go into the no surgery arm, or the patients who'd had a history of surgery before. And we can see, though, that across the board, dupilumab is improving their symptomatology and their polyp scores. And so this is something that as ENT surgeons, we need to take control of, because otherwise you're going to get respiratory physicians saying, oh, you've got polyps, I'll prescribe it. And there'll be no one that's monitoring whether or not there's more of a disease process. And there have been reported cases in the US where cancers have been missed because a respiratory physician has diagnosed the patient as having a polyp, when in actual fact, they've got an underlying malignancy. If we look at smell scores, this is very important. We can see that both get improvements in their smell on dupilumab, but if we look at intranasal corticosteroid use concurrently, patients who continue to use intranasal corticosteroids get a significantly better and a sustained improvement in their sense of smell, whereas it's a bit hit and miss if the patients aren't using intranasal corticosteroids. So certainly access is important, and again, why surgery probably should be contemplated before giving biologics, not just due to cost, but it does still allow us to actively deliver the steroid irrigations further back. And certainly for my patients, I'm very hesitant when I start them on biologics to just stop the topical corticosteroids altogether, because I certainly think we're treating sort of them superficially with the steroids. The mucosa is getting contact with the steroids, and the biologics is what's working systemically on that sort of submucosal inflammatory cascade. So I think there's a role to continue both and to titrate them accordingly. In this study, if we look at a response, a meaningful response according to the EPOS criteria, we can see that, yeah, a lot of patients did improve after the first month, but it wasn't really until they'd had about 6 to 12 months that they then transitioned into having an excellent response. So these biologics do continue to work in terms of quality of life and symptom improvement right out beyond sort of 6 months, and they are a prolonged treatment. The other study, the real-world study that I wanted to sort of bring to your attention was control of disease. And this is something that's really debated and has been a hot topic at recent meetings, and heated arguments have ensued of what do we determine as disease control? Is it symptoms? Is it symptoms and endoscopy? Is it how the patient is feeling, the need for concurrent medications? And I think probably the most sensible sort of assessment tool is the EPOS guideline at the current moment, where really it's a combination of everything. And what we're understanding from sort of inflammatory literature is that inflammation anywhere in the body may predispose to other chronic conditions and lead to cardiac stresses, for example. And certainly we're running a large database study that we're interrogating at our hospital at the moment, where we're looking at the incidence of cardiac events in patients with and without sinusitis, because there is certainly a school of thought that inflammation can lead to sort of atherosclerotic plaques elsewhere in the body, and may predispose to so many of these disease processes that are removed from the sinuses. So I think disease control, at least in my understanding, it should be not only the patients feel better, which makes them happy, but we really should see as little inflammation as possible. And so using those criteria, a German study looked at disease control and found that really, if we're looking at complete disease control endoscopically and symptomatically, these biologics only control about 10% completely. That the patients still have ongoing endoscopic inflammation in varying degrees of severity. Again, the reason for me as to why we need to continue the topical steroids beyond the commencement of the biologics. If we look at the disease control in that same cohort, this is only 41 patients, and again, it's an observational cohort. If we're looking basically purely on symptoms, these patients are controlled. And that's because they feel better, their quality of life's better, they're sleeping better, they're breathing and smelling better, despite still having some endoscopic inflammation when you look in their nose. If we look at the patients who have uncontrolled severe nasal polyps, and we look at the euphoria criteria, we can see that we're shifting patients from severe disease into an adequate response in the vast majority of patients overall with biologics. So again, I think this is food for thought. This is where we need to, as clinicians, do studies to understand what additional therapies we need to do for our patients, how long we need to continue them, and whether or not simply controlling their symptoms is enough for these patients, and whether or not we're really still trying to achieve long-term mucosal health and mucosal control. These are my personal experiences with dupilumab, and I thought I'd put a few of these in. This was a patient who presented to me. She'd said she'd had surgery 20 years ago. She was a severe asthmatic, wasn't privately insured, and didn't want to go through the 1 to 2 year wait in the public system, so took out health insurance. She was desperate to pay and wanted to pay privately out of pocket for her surgery, but I thought we needed to try something beforehand. And unfortunately for her, she had a severe asthma attack while waiting, for a surgical date. You can see prednisolone really didn't do a lot for her sinuses. It improved her maxillaries partly, and this scan was taken several weeks or 2 weeks after the prednisolone, but managed through a respiratory physician because of her presentation to the emergency department with status asthmaticus to get her on dupilumab. And this was her CT scan after 4 months on dupilumab. So you can see that the only surgery she's had done 20 years ago was maxillary antrostomies. And we've taken her, and I'll play the videos again, from really quite severe, almost steroid-resistant disease based on her lack of a significant response to the oral steroids, to a patient who has no symptoms and really very, very minor mucosal thickening of perhaps the maxillary and a few of the ethmoid cells, and avoided surgery. And this is a dramatic response to dupilumab in this patient. Does this mean the patient will never need surgery? I don't know. How long will we keep the patient on dupilumab? It's early stages in terms of our experience, but I think this was a really telling CT in terms of the effectiveness of some of these medications. This is another patient. This is a patient who initially presented with widespread sinusitis, almost completed pacification. They underwent surgery by me, and you can see that we've done mega antrostomies. We've opened up the frontal sinuses. Again, very few partitions left behind, maximal disease, couldn't get control of them. And that was the patient I showed you before with sort of that polyp recurrence. That was the patient who underwent the drill out that I showed you before. And this is sort of a pre-dupilumab. We're seeing sort of polyp recurrence. Patient didn't want another surgical procedure, had severe asthma. This is prior to mepolizumab being available. and had thick pus draining from the sinuses, managed to get the patient on dupilumab through my respiratory colleague. And, this is the sinuses after being on dupilumab. You can see there's not complete disease control, consistent with what we saw in that German study about disease control. But this patient's regained their sense of smell, their breathing, which they're really happy about. And they've got much better control than they had initially. So again, sort of a sign of dupilumab. So in terms of biologics for sinusitis in Australia, they've been available under the PBS for asthma since 2020. 2023, they became available, or mepolizumab did, for chronic rhinosinusitis with nasal polyposis. I've asked the reps from Sanofi as to why dupilumab is not available. It's purely a financial decision because the market is so big in the US and Europe, where the price and the reimbursement for the product is much greater than the government, that they don't want to introduce it into Australia yet for polyps because it will bring down the cost of what they can charge elsewhere, apparently. And so that's purely a financial reason as to why they haven't sought approval in Australia, which is, I suppose, disappointing, to be completely honest. If we look at what we do have available, mepolizumab, and these are slides that GSK have provided. Essentially, it works on interleukin-5, preventing its binding. We know that interleukin-5 is important in all stages of sort of eosinophil growth, proliferation, recruitment, and survival. And really, it tries to drop out the eosinophil count in these patients. It's given very easily in like an EpiPen type of device, which dupilumab isn't, which is in subcutaneous injections that they need to draw up and instill. So this is very easy, and it's given once every 4 weeks compared to once every 2 weeks, as dupilumab is. It really works effectively on reducing eosinophils. This doesn't always translate into what we see clinically, but these patients get a drop in the eosinophilia, which is quite profound, even within a month, and it stays plateaued for the full time that they're using it. The study that I suppose everyone has used and are basing their reason for introducing it into Australia in the market was the SYNAPSE study. Essentially, the criteria for this study were patients had to have had previous surgery, they had to have severe nasal polyposis, and they had to have criteria for this. They need to be considered, if they weren't to have this treatment, to be eligible for surgery again, and they needed to have symptoms and treatment with intranasal steroids. The obvious criteria were the ones that you can see there. They ended up including 414 of the 854 that were initially enrolled, and it was done across 11 countries, 93 centres. And essentially, it was delivered every 4 weeks, similar to the way that we deliver it now. Patients could continue on their steroids and their washes, and they were allowed to have oral steroids and antibiotics if needed. And these were charted as secondary endpoints to see whether or not a reduction in the amount of systemic therapy occurred. If we look at the two groups, relatively the same, placebo and mepolizumab, in terms of demographics, in terms of symptom scores, in terms of how long they'd had polyps for, and the time to since their previous surgery. The only areas that were slightly different was that the placebo group, the patients tended to have had more surgeries overall, so a greater number of previous surgeries if you look at those patients with more than one surgery. And these patients had a slightly higher incidence of aspirin-exacerbated respiratory disease and asthma. And you could argue that this perhaps indicates an underlying more severe level of global inflammation, given that they have these concurrent conditions. This was how they scored them, basically polyp score and a visual analog score of symptoms. And then the secondary endpoints, so they were the two first or primary endpoints. The secondary ones were the time to needing revision surgery, the change of their symptoms, individual symptoms, overall symptoms, and whether or not they required systemic steroids during the mepolizumab treatment. And what they found in terms of primary endpoints was that nasal obstruction significantly improved by a score of 4.41 compared to the placebo, and that nasal polyp size did reduce, and a score of 1 endoscopically isn't a huge difference. And certainly that's my experience with mepolizumab as well. You don't see the regression of polyps that you do see with dupilumab. In terms of their nasal obstruction score, we can see that over all time points, they improved compared to the placebo. 70% compared to 48% had a significant improvement in the nasal obstruction. I think the interesting data on the right chart is that patients who had less than 150 eosinophils didn't seem to do as well, which is why we have criteria for when we prescribe mepolizumab, so greater than 150 cells per microliter. And generally, the more eosinophils, the better their response in terms of their nasal obstruction. Interestingly, if you look at the sex distribution, the younger patients tended to do better. Patients over 65 seem to have not as much difference in terms of the improvement in their nasal obstruction than the younger groups. Does this reflect a longer disease burden with that irreversible disease phenotype creeping in? Or does it represent a different bimodal distribution of sinusitis? I suppose it's hard to know without interrogating the individual data of those patient groups further. In terms of nasal polyp score, again, similar findings. Nasal polyp scores improved in 50% of the patients on mepolizumab, only 25 or 27% in the placebo group, and the improvements in terms of greater improvements, more than just 1 point, was higher in the mepolizumab group. Again, if we look at the sort of data on the right, here we can see the 65-year-olds, it's again crossing that 0 point, meaning it's probably not a significant difference in terms of overall improvement in polyp scores. And again, when the eosinophils are less than 150, we're not seeing a significant difference between placebo and the mepolizumab group in terms of their polyp scores. This was other secondary data. 42% fewer patients treated with mepolizumab needed surgery. This was a surgeon's decision. So whether or not that's influenced by bias, it's hard to know, but overall, less patients on mepolizumab required rescue surgery in that 12-month period. And a lower proportion of them also required steroid rescue courses, and that was statistically significant. In terms of overall scores, the overall symptom scores were the improvement was much better, as we said, in the treatment arm compared to the placebo, as it was also on the SNOT-22 scale as well. Loss of sense of smell was a significant improvement, and this is something that I'm seeing in my patients. Although the polyps still stay there, they can smell, and they generally have a lot less secretions as well. In terms of adverse events, this is all adverse events. There were no serious adverse events that were thought to be attributable to the mepolizumab, and the rate was for serious events was really low. When you report any adverse event, if the patient gets a cold while they're on the medication, they can report that as an adverse event. If they get diarrhea from a gastrobug, it can be reported as an adverse event. And that's why you can see that the overall adverse events was high in both groups, which indicates that a lot of them probably weren't related to the mepolizumab. The respiratory physicians have been using mepolizumab for quite a long time for asthma, and they're not really seeing a huge number of adverse events. In terms of the adverse events that I see in my patients, I have had one patient with severe GI disturbances that warranted discontinuation. Patients often get low back pain for the first 24 hours or might feel a bit fatigued after the first 24 hours, but generally it's only for 24 hours and then they're back to normal. And occasionally patients get pharyngitis. I've had one patient with epistaxis as well. And here you can see from the study, nasopharyngitis was the most common. Some people get a headache, some cases of epistaxis, and that lower back pain is probably something that I see more commonly than the higher ones. In terms of how we give it, you're probably all familiar. It's pretty easy. The Nucala nurses are great, and they show us how to do it. Patient details, doctor details. You've got to get your hospital provider number, not your provider number, and then you fill in the rest of the details. evidence of poor disease control, which we all should do anyway, evidence that we've managed these patients appropriately, and the eosinophil count is something obviously that can't be fudged. They do need to show evidence. I do get my patients off any sort of steroid wash or prednisolone if they've been on it before I do the eosinophil count. I've seen some patients where they stop. Interestingly, they stop their Pulmicort and their eosinophil count goes up. Whether or not they're swallowing some of that Pulmicort, and that's why they're getting a systemic effect of it, I'm not sure. But certainly, if I think that they would be eligible, I'll stop there, and they're not getting a high enough eosinophil count, I'll stop it and retest them. I know Erin and Rejoy will speak very briefly about the registry, which I offer to all patients. I think it's a great initiative, and I think the more data we collect on our patients in terms of outcomes and also side effects will be important in how we then educate our patients when we consent them for treatment. They need to be reassessed at 5 months. They need to get a polyp improvement score of 1, or an improvement in their visual analog score for obstruction or overall symptoms in order to be continued. These are expensive medications, and certainly we need to justify that patients are getting a benefit rather than just continuing them on it. I won't go through sort of this data because we're getting towards the end of it. I'll speak to you about my personal experience in the last few slides. So as I said, I've been accessing biologics mainly through my respiratory physicians prior to 2023, and dupilumab was always my go-to. Although the respiratory physicians don't always like dupilumab for asthma, a lot of them like benralizumab, but certainly if I can get them onto dupilumab, I'll encourage my respiratory physician. I've had 31 patients on mepolizumab since 2023, probably reflective of my practice being tertiary, and the fact that I'm obviously inherit a lot of other patients who we do surgery for. We've had multiple surgeries in the past and they still have some ongoing inflammation. 20 have completed a 6-month course, and these are my figures. I've had one with severe GI upset who wanted to discontinue the medication of it, 2 patients with extreme fatigue, 3 patients with low back pain. Interestingly, of those 16 patients at 6 months, 13 wanted to keep going on with it. 3 discontinued, 2 because they didn't have a response symptomatically or endoscopically, and 1 because of the severe GI upset. I've had 3 super responders who their polyps have evaporated. All patients have been consistently using those topical steroids in those 3 responder groups. And I've had 10 where they have had significant symptom improvements. And what I'm seeing them reporting is mainly smell improves, their energy levels are better. If they've got asthma, it's much better controlled. And a lot of them say their mucus production reduces significantly. These are sort of a few of the patients I just want to show you. This is a 46-year-old male on with nasal polyposis. He's had 4 previous fessors. He's got asthma with aspirin exacerbated respiratory disease. That was his initial scan. And then we did surgery on him. He recurred. And he had a drill out in the end because of that initial disease. We've got the patient on mepolizumab, and the patient's done better. So this is the super responder. That was a patient I showed you before. Wait a second, let me just play that video again. So this is before starting the mepolizumab. So he's had a drill out based on the fact that I thought, he probably needed a wide opening. We can see those secretions. And when we give them the mepo, you will see the inflammation in this particular patient dramatically improved. So he's still got sort of scarring. He's had 4 previous surgeries, as we can see. He's got this tendency to form adhesions, but overall that frontal sinus cavity is better than it was. So he's done much better than most endoscopically as well. So he's not cured. He's still got ongoing inflammation, but this is a patient that would have polyps growing back. So every time you saw him, despite doing his Pulmicort irrigations. 9 months on mepolizumab, we can see that the inflammation is settling even further, and we're actually getting up into the sinuses on that patient as well. So he's continuing to improve, and generally I start to see most improvement after about 6 months in these patients. Certainly they don't improve as dramatically or as quickly as they do with dupilumab. This is a lady with allergic fungal sinusitis. anosmia. Here we can see widespread disease on initial presentation. And then this is before starting mepolizumab. So she underwent surgery after that scan as well. I didn't do a drill out on her. She was actually a lady that I presented at the AEST meeting back in Adelaide a couple of years ago, who kept developing this inflammatory tissue on her olfactory epithelium, which biopsied as polyps, not olfactory hamartoma. You can see sort of the thick eosinophilic mucin in the polyps in that olfactory recess. So we tried everything in her. And I remember presenting her asking for solutions. And on mepolizumab, we saw that the sinuses improved and that olfactory edema, which was contributing to a poor sense of smell, also dramatically reduced. So the sinuses look good. She's still got some thickening of that olfactory mucosa, but we can see that thick mucus was no longer there. And she got better with the mepolizumab. This is the patient, and I think this is more of a typical response of what I see. This is a patient where we can see their baseline symptoms are pretty bad. They've got a complete loss of sense of smell. They've got polyp recurrence bilaterally, quite significant inflammation in the sinuses. They're just one of these patients that just grumbles on despite what you do. You drop your head every time you see them. 6 months of mepolizumab, look at the symptom scores. She's gained her sense of smell back. All the other symptoms that were moderate have gone into the sort of mild phase, but she's still got polyps. We can see that she's not completely better in terms endoscopically. In this patient, you'd probably offer a drill out if you saw this patient and there weren't any options. She was adverse to any further surgery and wanted to try the mepolizumab. And based on her symptoms, she doesn't want anything further done. She thinks it's a wonder drug, even though when I look at it endoscopically, I still don't think we have complete disease control. Another patient, here we can see pretty significant polyps, thick mucus draining, awful disease, stenosing frontal drill out cavity. Again, that's reflected. Look how severe the symptom scores are on the VAS. We gave them 6 months of mepolizumab, and we start to see that inflammation improving. And look at the symptom scores. I mean, this patient still got moderate inflammation, but has no symptoms at all. And again, thinks it's a wonder drug. So for me, I use Nucala for steroid-resistant patients. It's not free of side effects. I do warn them about side effects. I also warn them about the unknown. We really don't know sort of long-term data other than what we're seeing in the asthma literature. And most patients, I would say the vast majority do feel benefit, and their benefits in olfaction, in my experience, and in the reduction in secretions, and certainly not an elimination of the polyps we see in their nose. If they're not responding to the mepolizumab, I still try to access dupilumab through a respiratory physician, provided they have asthma, but obviously that's dependent on asthma. And I suppose the question is, why don't we go straight to biologics? Well, I think this paper sums it up. We can get a lot of our patients a lot better with good surgery and good post-operative treatment. And this is a summary of all the surgical outcome papers from, I think, 2008 to 2016, just before the paper underwent, or the study was undertaken. And we can see that we get a minimal clinically important improvement of 24.4, which is well above that 8 to 9 cutoff range, which was similar to what we saw with dupilumab in patients. So surgery still works, and there's still a role for it. And I still think we need to be good surgeons and do good surgery. The other reason we don't go straight to biologics is the financial reasons. And certainly at the moment, in the States, you can see the figures there, and in the UK, biologics are exorbitantly expensive to the healthcare system. And really, to get one improvement in quality of life over just doing surgery, you're spending 10 times the amount on that patient. And so really, I think we do need to be the protectors of our healthcare system and our healthcare economics, because the pot will run out, and we really won't have medications to treat our patients if we just give everyone these expensive treatments as a first line. I think the other reason we don't go straight to biologics is when steroids were developed by the Mayo Clinic in 1948, they were heralded the wonder drug. patients felt better, aches and pains went away, chronic rashes, arthropathies all seemed to dissipate. But then we started to understand, as these became more in our everyday prescribing, the long-term side effects. And it's interesting that in the same year that the Mayo physicians who developed steroids were awarded the Nobel Prize, they actually publicized that we really shouldn't call these things that patients are experiencing when they're on steroids side effects or toxic reactions. They're simply just physiological alterations induced by cortisone. And so they were defending steroid use. And it really wasn't until sort of 20 years later that we started really getting people saying, wait a second, steroids probably aren't as safe as we think they are. They probably shouldn't be a first-line treatment. And really, we need to be exhausting the safe treatments before we start prescribing steroids. And when we do prescribe them, we really need to be speaking to our patients about the risks and evaluating whether or not they're contraindicated. And I've often heard, well, there might be a role in the future to give multiple biologics. When we start thinking about that, eventually we're just probably going to be replacing steroids, oral steroids, with multiple different injections, which is suppressing the inflammatory cascade. So I really think we need to watch this space. We need to document the side effects so that we can really consent our patients appropriately. Thank you very much. Hello?
Thanks, Alki. Before we move on to Rejoy and Erin, are there any questions for Alki, or Ray's giving you a hand clap emoji? Are there any questions or comments?
Yeah, Alki, can I ask, the glaring thing here, Alki, is that we have colleagues overseas in Europe who are reporting registries where the polyps go from 7 or 8 down to 0. I must admit, like you, I've been fortunate to have access to dupilumab through respiratory system. I don't see that in my dupilumab patients. And like in America, they talk about when's the right timing of surgery for dupilumab. And when you look at the control arm of dupilumab and no surgery, it's much closer to the phase 3 trial, the data. It's still amazing. Let's get it. Let's not undertake it, the benefit. It's amazing benefit. But what do you think's going on with the difference in data reporting around the world? Do you think like Americans and Australians have been achieving remission with big surgery and topicals, and Europeans have never seen it, and they're a bit overcalling it? What do you think?
I think there are two reasons, Richard. I think the extent of surgery in Europe is very different to what we do in Australia. And certainly, even in the US, having done 2 fellowships in different locations, the extent of surgery we did in South Carolina was very different to the extent of surgery we did in California. And the disease processes were very different. We saw a lot more severe disease in South Carolina, similar to the Australian patients, and probably more of that lymphocytic neutrophilic inflammation, although there were polyp patients, less of that in California. And I can't describe, well, I don't understand completely the geographical differences. Obviously, environment is something. But if you go to European conferences, they've always been very conservative. And you know that, I know that. And what they talk is complete surgery, we would possibly consider a mini-fest at times. So I think, number one, we're very confident at performing complete surgery. I think Europeans are a little bit more conservative. I think their training is probably not to the same level, not in all centres, but a vast portion of them. I think also the other thing that we're seeing, Richard, is that the people that are purporting these benefits are probably similar to the Mayo physicians. They've all got skin in the game. A lot of them were the inventors of biologics. A lot of them are still on the consulting board for biologics. So I think we can't underestimate possible bias in reporting, whether, I suppose, deliberate or not
enthusiasm.
Yeah, probably enthusiasm. But Richard, if it was the case, you and I would be seeing dupilumab evaporating away disease completely as well. And for me, that German study, which looked at control in terms of endoscopic and symptomatic control, is probably more realistic of what you and I are seeing in our dupilumab patients, where symptomatically they feel great, but they've still got ongoing inflammation visible endoscopically. And if we look hard enough, we'll find it.
Can I just point, like, to support your algorithm about really making sure that the sinus cavity is good, is I went to LA recently and I gave a talk at Cedars-Sinai. They've got 100% access to dupilumab. They just have to tick a box. They can get it improved in California. Yet my colleagues there still don't use it until they've done complete surgery or the revision FES or something they think is, you know, especially if the asthma is not bad. So almost like your algorithm, for people who've had it now for 5 years, where they can just tick a box and get it, they still seem to hold off on applying it until after they're happy that they've got a cavity, as you said, you know.
And I think we need to be the stewards, Richard. I think we need to make sure our patients having complete surgery, and if we don't think that we can take it to the next level, refer it on, because you can be saving the government a lot of money, and our healthcare system from simply just ticking the biologic arm, and then telling the patient that there's nothing more that we can do, which unfortunately is sometimes what happens.
Well, the thing, Alki, is that I got the feeling from them that they weren't ticking it just because they were trying to be good health resource managers. I actually think that they were not ticking it because they actually had seen a lot of people put on dupilumab and not a result that was commensurate with the cost.
Yep.
That's what I would say.
I think there's 2 questions, are there? I think from Yi, when would you stop biologics? What happens when you stop biologics? I haven't used them long enough, Yi. It's a good question, and I don't think anyone really knows. You can develop antibodies. There's now literature emerging that you can develop antibodies to biologics. It's a low rate, but they are developing. I think from what I understand from the meetings is that, you know, 2 years is when they will reassess it, and they may have periods where they take them off the biologics and sees what happens. But I don't think there's been a long enough time around for us to truly understand, you know, when we do. We know for asthmatic patients that some patients become treatment resistant, having been on biologic, you know, one particular biologic for 3 or 4 years, and then they get switched to another biologic. And I've certainly seen that in a few of the respiratory patients that I co-manage. I think that's an area that we're still waiting and seeing, and we don't have the answers to yet.
Thank you, Alki. Would Erin or Rejoy like to share their screen?
Thank you. Thanks, Rowan. Thanks, Alki and Richard, for having me along. I'll just get my slides sorted. Can everyone hear me while I'm doing that?
Yes, we can.
Great. Hit share. There we go. Okay. Is that all working?
Yep, perfect.
Yep. So my name is Erin Harvey. Thanks for the introduction, everybody. I'm with the University of Newcastle. My colleague, Rejoy Sabin Thomas, he's also there in the list of audience members. And he's quite involved in the day-to-day running of this registry. And it's being led by Professor Richard Harvey and Professor Peter Gibson in respiratory. My background previously and still ongoing, in fact, is that I have managed the Australian Mepolizumab Registry for severe asthma and been involved in some of the other biologic registries in the severe asthma space. And I recently, in the past year, helped set this registry up along with the team. So I'm happy to give a bit of an intro. I know some of you in the audience are already involved in the registry, so you'll be familiar with it, but I'd like to give you a bit of a data snapshot and also tell you a little bit, for those who don't know, about how we're conducting the registry.
And so, not related to myself in any familiar way, except for past days.
No, Richard does like to make that clear. Thank you. I have a biomedical science background, and as I said, I'm in respiratory prior to this. So I will move on. So the objectives of the registry are to document the use of mepolizumab in Australia for patients who suffer from severe chronic rhinosinusitis with nasal polyps, to provide insight into the characteristics of these patients and to report on the real-world effectiveness and safety of mepolizumab in these patients. Participants of the registry are individuals aged over 18, and are those patients eligible to receive mepolizumab for their chronic rhinosinusitis with nasal polyps, both within the PBS criteria and also outside of the criteria. It's a simple registry design. We're characterising the participants at baseline prior to treatment commencement, and we're reporting on outcomes at a 12-month follow-up. The mepolizumab is prescribed per your routine practice. It's not given as part of the registry. Data we're collecting, obviously, demographics, key clinical information around diagnostics, diagnosis history, severity, outcomes data, and some patient-reported symptoms and quality of life measures as well. And quite a bit of medication data, including, importantly, the oral corticosteroid use. For those not involved in the registry, we are using a centralised telehealth model for data collection. So sites involved in the registry basically identify patients when they're preparing to apply for mepolizumab treatment for the patient. They refer the patient's details to our team in Newcastle. We confirm eligibility with the patient, eligibility for the registry. We enrol them in the registry and complete a data collection interview. And this is all done via telephone and online surveys. And we then also conduct an interview at that 12-month point and have the patient complete surveys. And we combine this data with the clinical data held by the sites. We started enrolling participants in August last year. As of today, we have 80 patients enrolled, and we're aiming for 140 by the end of this year. And patients have been enrolled, are referred from 12 sites around Australia, as you can see there. To give you a little bit of a quick snapshot of some of our baseline data, I wish I had follow-up data, but we're not actually at the point of collecting that yet. The patients have a median age of about 52 years. They're predominantly male. They have a BMI of about 26, almost 90% are Caucasian, and about 43% have got a history of smoking. Just moving my little people there, okay. In terms of history of disease, so their age of symptom onset is a median 25 years, and their diagnosis age is a median 34 to 35. The median age of first surgery for these patients is 36 years, and they report having a median of 2 surgeries in total prior to baseline. In terms of some of those baseline characteristics, they have a baseline peripheral blood eosinophil level of 495 cells per microliter. You can see the symptoms VAS scores there. They have a nasal obstruction score of 8 and an overall symptom score of 8 as well. Those are medians, and we're having those collected within 4 months prior to commencement of mepolizumab, specifically for the registry. In terms of the nasal polyp scoring, you can see they have a total score of 5 there, and the Lund-Mackay scoring is down the bottom as well. Just drawing your attention to the graph on the right, almost 82% of the patients currently enrolled have asthma. 37% gastroesophageal reflux disease, and about 24% have aspirin sensitivity. This is patient-reported diagnoses of these comorbidities. On the left here, you can see the baseline SNOT-22 scores. So they have a total score of about 59. And in patients with asthma, we are also having them complete the asthma control questionnaire score. So they have a baseline ACQ-5 score of 1.25. That's all for the data I'm going to show you. I do look forward to sharing follow-up data and a lot more extensive data in the future. But I would also like to acknowledge all of those principal investigators and their teams involved, Rejoy and Dr. Cara Morris, who are involved in a lot of the data collection, and the sponsor, the University of Newcastle. So if you would like more information about the registry, if you'd like to refer patients, please get in contact with Rejoy or myself. Rejoy's details are there, and the QR code will help you as well. Thank you.
Thank you, Erin. Are there any questions for Erin or Rejoy about the registry? Erin, we've got your details, so I guess if anyone has any questions, they could always get in contact with any of those investigators to ask any further questions.
Of course. No, that sounds great. Thank you.
Awesome. Richard,
can I ask Raven?
Oh, yes, go for it.
I mean, I have a number of patients who are on Nucala at present, and I've been collecting SNOT-22s and Lund-Mackay, Lund-Kennedy scores. Can we put them onto the registry retrospectively?
So we didn't set out to enroll patients retrospectively. However, we have had a few discussions about it recently, but have not yet decided to go ahead with that. But we can provide update if we do, particularly if most of the data is there.
So at the moment, it's anyone that you're thinking of commencing on mepolizumab, it's at that point that we get in contact with Erin or Rejoy at this point in time. That's
right. Yes. That's the
Thanks.
ideal scenario. Yep.
Fantastic. Thank you so much, Erin. I'm just going to quickly talk about our next webinar. So our next webinar is going to be in 2 months' time. The speaker is to be determined. It'll be an immunologist, but also just as an announcement to all members that the annual general meeting will also be at our next webinar in August, which is 12 months after our last one, which was in Fiji. Unfortunately, this one will be virtual, not quite as exotic. But we'll certainly send an email out with the minutes of the last meeting plus the details of the next webinar. But otherwise, I'll bring the meeting. Thank you so much to Alki for that incredible presentation. It's not many people that can keep us engaged for over 45 minutes, Alki, so well done. That was fantastic. And we'll send out more details about the annual general meeting. Thanks a lot, everybody.
Thanks, everyone. Good night.
Great talk, Alki.
Thank you. Thanks, guys.